Intestinal anastomosis and resectioning. By definition, it is the excision of necrotic or infected intestinal tissue following the positioning of the intestinal tissues together. It is indicated for the removal of infected or necrotic tissues, irreducible into susception, neoplasm, and stenotic intestine.
For the anatomy, the small intestine is the initial portion of the intestinal tract. It is basically a tube beginning at the pylorus of the stomach and ending at the ileocolic valve. It measures about 3.5 times the length of the body, or the average length is 4 meters or 13 feet. The layers of the intestinal wall are the mucosa, submucosa, muscularis, and serosa. Mucosa is an important barrier that separates the luminal environment from the abdominal cavity.
Preoperative techniques. As per usual, the operating room was prepared in a sterile manner. The table was draped, and all the surgical tools and instrument to be used was organized. The surgical team observed asepsis by performing the surgical scrub and proper gloving. Prior to the surgery, the small intestines to be used was cleaned and prepared. So here are some documentations of the preparation prior to the surgery.
Next is the intraoperative techniques. First is the end-to-end anastomosis. First step is to excise the necrotic portion of the intestine using a stabbing blade number 11, and continue using surgical scissor. Make sure to remove at least 2 to 3 centimeters of the uninfected area of the intestine to prevent reoccurrence. Make two stay sutures, one on the anti-mesenteric border and another on the mesenteric border. To close the incision, use cushing suture using 3O chromic sutures. Cushing suture yung gagamitin para inverting siya and ma-prevent ang leakage. And also make sure to not to penetrate the lumen kasi that will also cause leakage, and the suture will be absorbed quickly, or tutunaw siya due to the stomach acid. Next is to check for leakage. Clamp one end of the intestine using a hemostat and push water on another side. Then side-to-side anastomosis. Position the intestine wherein the anti-mesenteric border are close to each other. Put two stay sutures on the anti-mesenteric border of the intestine. Then stab the intestine using blade number 11 and continue the incision using surgical scissors and groove director. Repeat this step on the other intestine. Make sure that the two incisions are of the same length para mas madali siyang i-close and walang leakage. To close, suture the posterior side first. Use 3O chromic with cushing suture technique. Repeat this step on the anterior side of the intestine. To check for leakage, clamp one end of the intestine using a hemostat and push water on another side. So for side-to-side anastomosis, meron siyang not viable na parts. Yung not viable parts na yun, kailangan as much as possible is konti lang yung matitira dun para maganda pa rin yung flow ng food sa intestine. Lastly is the end-to-side anastomosis. Position the intestine wherein the end side is close to the anti-mesenteric border of the intestine. Make a stab incision on the anti-mesenteric border of the intestine using blade number 11, and then continue the incision using surgical scissors and groove director. Again, to close, use 3O chromic sutures with cushing technique. To check for leakage, clamp one end of the intestine using a hemostat and push water on another side. Yan. Again, sa hindi viable na part ng end to side anastomosis, as much as possible is konti lang yung matira doon para hindi ma-stuck yung flow doon. Flow ng food doon sa part na yun.
So, complications of the procedure. 1 is stricture or stenosis. This is going to happen if the suturing ng intestine is too tight, hence narrowing the lumen of the intestine, kaya nagkakaroon siya ng stenosis. And another one is fistula. This will happen kapag nag-through and through yung needle habang nagsusuture, or kapag masyadong maluwang yung knot ng pagkakasuture. So, magkakaroon siya ng opening. So, this opening will lead to leakage. Tapos, yung leakage is mapupunta sa other parts or organs ng abdomen. And lastly is infection. So, infection may occur dahil dun sa leakage from sa fistula, or kapag yung mga ginamit na instrument during the surgery was not properly sterilized, or 'di ba, dahil nga contaminated surgery din to, gaya ng sa stomach, kailangan na kapag nagsa-surgery, once na nag-open ka, yung gagamitin mo na pagko-close is another tools, yung malinis na tools, kasi magkakaroon ng contamination sa other parts or other organs. So, ayun lang.